Dr. Bret Scher, welcome to the show.
Thanks, Ty. It's a pleasure to be here. Thanks for having me on.
Yeah, well, excited to talk to you. You're a cardiologist, and you've also become one of the leading voices for the low-carb and ketogenic community and different approaches. And you've said before that you were trained to be wary of fat and consider carbs the foundation of a healthy diet, kind of like the old pyramid back in the 90s and early 2000s. So what changed your mind?
What changed my mind was seeing my patients and how they responded to low carb and keto. So this was, 15 plus years ago or so. I started a little wellness center with a friend of mine who is a really good health coach and personal trainer. And it came out of this just frustration that people weren't getting better the way I thought they would. You know, it wasn't like I had dreamed in my fellowship that I would get out into the world and just help everybody prevent heart disease and stick to these healthy lifestyles. It just wasn't working. So I thought I just needed to spend more time with them. So in addition to my regular cardiology job, Dustin and I started this wellness center. And for a couple people who really were struggling with type 2 diabetes and hypertension and their weight, he said, hey, why don't we try a ketogenic diet? And I said, what are you, crazy? Like, I'm a cardiologist. I can't put people on a ketogenic diet. I'm going to kill them. That was my first reaction, right? Because that's how I was taught. Yeah. And he said, well, have you actually looked into it and read any of the papers about it? And I said, what do you mean papers? There's no research on this. And actually, to my surprise, there was research. You know, Dr. Westman and Yancey had published papers and there were books about it. And so when I sort of dug into it a little bit, I was like, all right, let's give it a try. I tried it on myself, tried it on the patients, and it really opened my eyes. And it opened my eyes in a way that, and on the one hand, was super encouraging. Like, oh my God, here's this tool in the toolkit that is so beneficial for people. And on the other hand, made me incredibly frustrated. Like, why did I have to hear about this from my friend who's a personal trainer and a health coach, where here I've spent how many years learning medicine and learning how to take care of people and was never taught or told anything about this? So I was frustrated and encouraged at the same time. So since then, it's just kind of gained steam for me that I kind of feel it's my duty to make sure people understand this is a medical intervention, and not that everybody needs to be keto, right? Everybody needs to be in ketosis. Absolutely not. But in the right setting, keto and especially and even low carb can be incredibly beneficial as a medical intervention. And unfortunately, our dietary guidelines and our medical teaching has been contrary to that, like really teaching the opposite and teaching that is dangerous, which is a real blind spot that we have to change to start helping people as best we can.
Wow. And it really does sound like there's this bias against keto in sort of modern medicine, even in the dietary recommendations that we've had for many years. That may be changing, hopefully. But, what drove this and how does it show up in clinical practice? Like, do you still see patients, or when you did see patients, do you have people come in thinking, I need to be eating a lot of carbs, and they're not sort of aware of the low carb approach? Or do you see more people are open to this and they're ready to try something different?
You know, I see a mix. So I still practice as a preventive cardiologist. I'm no longer in sort of the standard cardiology job in the hospital and so forth. But when I was, interestingly, I sort of carved out a niche that I was, treating people with low carb, and people were coming to me because they're like, I can't find a doctor anywhere else who would recommend this. And so just because of sort of who I was and my message, I was getting people who were open to it. But there were also plenty of times where I would bring it up with someone who hadn't heard of it. And of course, they all thought I was crazy because it's exactly the opposite of what they are hearing. Now in my practice, I have sort of a small preventive online practice where it's mostly people looking for someone to help them with low carb. But at the same time, I also, I'm not the one to say only low carb and only keto. And I have patients who I, work with higher carb diets. And so I realize there are other ways to go about doing it. But we just really have to be open to this concept. And there is that barrier for a lot of people. Like, no, that can't be right. I've heard how terrible that diet is. And I've heard how much you need carbs and how healthy whole grains, right? Just the term healthy whole grains, healthy grains, heart healthy cereals, and the Mediterranean, high carb Mediterranean diet. There are these terms that really mean nothing, right? They have no clear objective definition, but in people's minds, they carry a certain weight. So sometimes you do have to sort of get over that initial bias or that initial thought process, I guess.
Yeah, I've seen it in my own personal life when I talk with doctors, family practitioners especially. I I'm curious, how do we sort of shift that to where modern medicine, mainstream medicine is sort of updated with that approach? Not to say, like you're saying, we don't need everybody to go keto. That's obviously not required. It's not necessarily optimal for everybody. But sort of, how do people find, I imagine people come to you specifically because they've probably been to a lot of preventative cardiologists or, family doctors that have sort of given them the same sort of advice that maybe you offer something different to. So is there a way, are there any efforts out there to make this more mainstream for people?
Well, I guess I'm sad that you even have asked that question, because it's my life's work. What I'm doing is to try and make this more mainstream and make people aware of it. But, we're just trying to get information out there as much as possible. So whether it's at Metabolic Mind, where we're focusing on ketogenic and metabolic interventions specifically for mental illnesses and brain-based disorders, our YouTube page, our podcast, our website, all the individual stories that we share, the Think Smart platform, we're really trying to get that information out there, plus funding research with Bazooki Group, just funding more and more research to help further this, creating free CME activities for people. And then the same thing with the Coalition for Metabolic Health, really trying to help on a policy standpoint. And as we saw with the recent guidelines, the recent dietary guidelines, acknowledging low-carb diets as beneficial for people with metabolic disorders, so that should absolutely be consideration. I mean, that's huge to make that into the guidelines, and really does give me some encouragement that now people are going to take note. But also, again, research, CME, education, whatever we can do to get this in front of as many people, and not just the doctors and clinicians, but the people looking for themselves to improve their health so they can understand and bring these materials to their doctor to help educate their doctor. So yeah, I mean, it's a pretty big push to get it out there. Now it's hopefully in its infancy and just going to grow and explode as we get more information, and hopefully with the help of these guidelines to help people recognize that, yes, people with metabolic disorders need a different lifestyle and dietary approach, and low-carb and keto is absolutely one of the more effective approaches for that.
Wow. I'm so thankful that you're doing all that work, and I've been aware of some of it and been involved in, obviously, the Coalition for Metabolic Health. So it sounds like we're really trying to come at this from educating the consumer, educating the practitioner, and the policymaker, right? Doing all three of those levels at the same time, which is really needed, because you can't really make the progress needed with just any one of those areas. So let's talk about heart disease. Let's talk about metabolic health. Cardiovascular disease is the leading cause of death in the U.S. still. I think we've seen a lot of declines over the last several decades, but it's still the number one cause of death. So what are we getting wrong about prevention? What is the primary driver? Why are we so sick?
Yeah, I mean, I hope I don't sound like a broken record, but I think what we're getting wrong is just not focusing enough on metabolic health, not understanding its importance. Because the focus, rightly has been on tobacco, right? Getting people to quit smoking. Absolutely. Even though it's observational data, it's some of the strongest observational data we have. There's not much of a question about that association, right? So getting people to quit smoking, absolutely. And actually, when you talk about sort of death or, morbidity and mortality from heart disease, our interventions with the stents and the angioplasty and what we call the door to balloon time, getting people in to the hospital faster, that is phenomenal. Like, cardiology is outstanding at doing that and has made incredible gains. So a lot of people point to statins and the use of statins and cholesterol lowering, which I'm sure has had an effect. I would argue maybe not the effect that people have had, more attention to blood pressure with medications. But what we have absolutely failed to do, is to address the broader metabolic health with lifestyle interventions that are effective and that people can do and stick with. We have been an abject, absolute failure in that field. And I think that's a big reason why we haven't really gotten a hold of heart disease. When you see obesity and diabetes and pre-diabetes just rising in terms of their incidence, that really tells you something. And there was that publication, I think it was 25 years of the Women's Health Initiative follow-up, where they looked at when they measured initial blood tests, what most predicted the development of heart disease. and it was either having type 2 diabetes or having insulin resistance or even high triglycerides. And ApoB and LDL were on the list, but they were dwarfed by metabolic health. So that, I think, to me, that shows we really have gotten it backwards and haven't had the impact we've wanted because of that.
Wow. And I know that a lot of people, when you hear about heart disease or risks, first thing people think about are cholesterol, right?
Mm-hmm.
So what is the cholesterol? And people often also confuse sort of the dietary intake of cholesterol with the blood levels of cholesterol. You know, we know total cholesterol is not the best marker. You've been, very critical of LDL as a marker here. How do you think about the role of LDL? Is this sort of a part of the issue here? Do you really focus more on the ApoB part of that equation? Where do you stand?
Yeah, so LDL and ApoB, I mean, first, the concept is pretty much the same, right? They're markers of cholesterol that can get retained in the vessel wall and lead to plaque development. Okay, so it's absolutely involved in the process and absolutely is a risk marker that should be followed and should be addressed in appropriate circumstances. Whether it's LDL or ApoB, I mean, ApoB I think is better because it captures more of the metabolic dysfunction. I actually just did a video at Metabolic Mind about the difference between LDL and ApoB. And what ApoB does is it helps reflect the size of the particles and whether there are remnants like VLDL and IDL. It doesn't directly tell you that, but it indirectly tells you that, as well as Lp(a). And these are all terms, I'm sorry if people aren't familiar with these terms, but basically they're all more instructive than just LDL. They tell you much more than just that LDL number. So ApoB captures that. So it definitely is the better marker. But it doesn't mean that ApoB is now the end-all be-all and best marker. It's still metabolic health is more important in my mind, but ApoB still should be considered, and it helps reflect a little bit more of the metabolic health than just the LDL cholesterol.
Right. Okay. And I have a relatively high ApoB, moderate ApoB, but I have a high Lp(a), which is a primarily genetic driven risk factor. So I have to sort of, my understanding, pay more attention to the controlling my ApoB levels. But like you're talking about, primarily metabolic health, it's a complex picture. How is your insulin? How is your blood sugar? How are your triglycerides? Let's talk about diet a little bit. When I have more carbs, my triglycerides go up quite a bit.
Yeah.
When I have saturated fat, my ApoB doesn't actually change compared to when I reduce it. So there's these individual factors too. And I know, we've talked a little bit about offline about David Unwin's work in the UK. He's sort of done a lot of stuff with his diet and lifestyle, especially the low carb. He's had over 100 patients go off of type 2 diabetes without drugs. So looking at just diet alone. So the diet can be powerful. Can you tell us a little bit about the role of lower carb and then even ketogenic diets in treating metabolic conditions, and also how that sort of works within the cardio metabolic world in terms of heart health?
Yeah, so that's a big question. There's a lot there for sure. And before I even answer that question, I just want to reflect on something you said about, metabolic health being sort of a complicated term and, blood sugar and insulin. But here's one of the problems is we frequently just use blood sugar as a diagnosis for metabolic health. Either you have prediabetes or diabetes, or you don't. And if you don't, you're quote unquote metabolically healthy. And if that's all we're using, that is just not even the tip of the iceberg. I mean, that's just not even scratching the surface. So there really are all these other factors that come into play, whether it's a fasting insulin, what's called a HOMA-IR, triglycerides, HDL, that ratio, the LPIR, which is looking at lipoproteins that reflect insulin resistance. So there's so many better tests we can be using and more informative tests than just glucose. So then, how does diet reflect that, or how does diet impact that? And I'm really glad you mentioned eating higher carbs raises your triglycerides. For you, eating more saturated fat does not raise your ApoB. And I think that's so important because there is this just assumption that you eat more saturated fat, your LDL goes up, your ApoB goes up, end of story. But that is actually not the case. So again, I did a video about this in Metabolic Mind about how important, one, where the saturated fat comes from, and two, what is the rest of your dietary matrix? Are you eating high carb, high fat, or are you eating low carb, high fat? And it is completely different. And we have to understand how our bodies respond to quote unquote saturated fat is completely different depending on the setting. Is the saturated fat coming from pizza and ice cream? Is the saturated fat coming from a steak that you're eating with, broccoli and avocado in the setting of a low carb diet? Completely different scenarios. So we can't talk about fat as one thing. We can't talk about saturated fat as one thing without considering where it comes from and what's the rest of the diet. So there's absolutely, whether it's looking at Dr. Unwin's clinical practice or their clinical practice at Virta Health or Toward Health, or the published studies, the numerous published studies showing that low carb and ketogenic interventions are one of the most effective dietary intervention for not just treating type 2 diabetes, but putting it into remission, right? There's this concept that I was taught, certainly when I was in medical school and residency, that type 2 diabetes, you have it forever, and you just try and control it and try to mitigate the complications that are going to eventually happen, but you're just trying to delay them. Now, that conversation has been flipped on its head, that these dietary interventions can actually reverse or put the disease into remission. It's not a quote-unquote cure, because if you go back and start eating the old way, it's probably going to come back. But you can absolutely get rid of all the signs of type 2 diabetes. And I don't want to just say diet is the only way to do it, right? Physical activity, sleep, stress management are all important. But when you talk about the biggest contributors, it is without a doubt diet, and low carb and keto isn't the only way to treat it, but is likely the most effective way to do it.
Wow. And I should just say that my version of saturated fat was whole fat Greek yogurt, eggs, right? Some meat, some seafood, that type of thing. It wasn't just a bunch of tallow and whatnot. And I wasn't eating this ultra processed, highly refined diet as well, right? So that context matters, and the individual matters. So everybody's different. And from my understanding, some people, they may have their certain cholesterol levels increase on higher saturated fat. So it really depends on the person here. Now let's talk about any sort of potential risk of the low carb. So one of them is certainly we see some people's cholesterol levels may go up. They may not go down to optimal ranges potentially. How do you work with people in that context? Are you concerned about the cholesterol, or is it like if every other marker is okay, do you not really worry? What's your stance there?
Yeah, and the answer is it depends, which I know is not an answer people like to hear. They want a clear answer, but it really does depend. And so like you said, some people, LDL ApoB doesn't change at all. Some people it goes up a little bit, and some people can go up really high. So the people who it doesn't change at all or goes up a little bit, usually if I'm going to make a blanket statement, I'm not too concerned about that, because it's almost always in the setting of metabolic health improving, blood pressure, triglycerides, HDL, blood sugar, insulin. If all those things are getting better and LDL goes up a little bit, I'm usually not too concerned about it. And in fact, that's exactly what we see with the medication class, the SGLT2 inhibitors, Farxiga and others, that, I don't know, to use a bad phrase, are sort of the cat's meow in medicine that everybody wants to use, because they reduce cardiovascular events, they improve renal function, right? They lower blood pressure a little bit even. They can even help you lose a little weight, and they raise LDL. But nobody talks about that because of all the other beneficial effects. So for me, that's sort of the equivalent of what you usually see with a ketogenic intervention. Now, for those who do have a pretty extreme rise in the LDL, so-called lean mass hyperresponders, and you don't even have to be a quote unquote, to fit all the criteria, but some people still have that LDL go up. Is that a problem? And again, the answer is it depends. All things being equal, I would rather it not happen, right? But you have to, the way I approach it is within the full cardiovascular workup. So I think imaging is crucial. Do you have pre-existing plaque? If you do, I'm going to treat you very differently than if you don't have pre-existing plaque. Now, some people, even without plaque, it may be worth lowering that LDL, and some people it's not. But if you have pre-existing plaque, to me, that definitely raises the stakes, because I think LDL is more impactful in plaque progression once it's already existed. So then maybe we're going to be a little bit more aggressive. But again, what's your family history? What other risk factors do you have? What's your metabolic health? And what are your wishes, concerns, desires, right? All those have to play in to how do you approach it and how do you treat it. So I think your question was, is it something I worry about? And I guess the answer is yes, in terms of worry, meaning it's part of the algorithm, it's part of the consideration, it's part of the workup. Absolutely. I would never ignore it. But I'm not going to see a number and be like, oh my God, we have to treat that number. I'm going to see that number and be like, okay, let's put that into context with everything else and then see how we can progress from there.
Okay, so you look at the full picture, right? It's a lot more than just one of these markers, right? And so I'm interested also in when you do have somebody who's really trying to optimize, okay? Let's say they just really care about their overall health and their longevity, long-term. Everybody's different. The family history totally matters, whether they have plaque, how much, all of that. But in general, do you use cholesterol-lowering medications as part of this approach? And how do you view those as, do you see trade-offs? Do you see certain types of medicines will increase other markers like maybe blood sugar or insulin control? How do you see that?
Yeah. So I absolutely use cholesterol-lowering medicine in my patients when it's appropriate. And so that's part of the workup. So I use statins, I use Zetia, I use, PCSK9 inhibitors. Sometimes I'll use supplements as well, or instead of. So there are a number of different approaches for how to do it. And again, it's got to be individualized for the patient. But now I think what you're referring to is how statins absolutely can worsen insulin resistance, can raise blood sugar, can raise insulin levels. Fortunately, that's not actually something I see in the majority of my patients who I treat with statins, because they are all prioritizing their metabolic health, right? They're exercising, they're eating low carb, they're prioritizing their sleep. So I think there's really something to that. Now, for those people who are more prone or already experiencing prediabetes and poor metabolic health, absolutely statins can worsen that. So it's something to be aware of. But since most of my patients are taking the steps to prevent it anyway, I don't really see it. Now, questions about, could there be muscle side effects? Could there be cognitive side effects? Muscle side effects absolutely happen, less so with Zetia and the PCSK9 inhibitors. Cognitive one is a big issue because the data is a little bit all over the place. There's some data saying no relationship. There's some data saying clear relationship. And that still has to be sussed out, but something that I want everybody to pay attention to. Absolutely. I mean, it doesn't do any good to try and prolong longevity or reduce heart risk if you're going to speed up dementia and cognitive decline. Not that I think that's a high risk with lowering LDL, but I think it's something to keep in mind and consider and pay attention to.
Right. Okay. Now let's talk a little bit more about GLP-1 drugs. So we haven't really gotten into that, but we're talking about diet. Now, how do these drugs, which have been lowering in cost, there are a lot of studies looking at maybe getting a pill form more available. How do these drugs play a role in this? And do you see these as a replacement for dietary changes, or do you see that in like you still got to do both?
Yeah, I think the biggest problem with these drugs is they are promoted in a way that suggests they're replacing dietary interventions and lifestyle interventions, that they are now first-line therapy, where lifestyle interventions absolutely should be first-line therapy. It doesn't mean you can't get a GLP-1, but you got to talk about it with lifestyle. So actually, earlier we talked about the Coalition for Metabolic Health, which you are thankfully a part of. So we just had a task force on GLP-1s, and we created a statement that went over sort of the main points that's on our website at Coalition for Metabolic Health that I really encourage people to check out. We convened a group of experts to create this statement. But basically the concept is, look, these drugs work better for weight loss than anything we've seen, but that doesn't still make them the best treatment, because even if the cost is coming down, there still is a cost. They still have potential side effects. And it's that old question, are they sort of just putting a Band-Aid on it without getting to the root cause, treating the symptom without the root cause? That's a concern. And also that there's skeletal muscle loss, there's lean muscle loss. And, I've heard people say, oh, well, that's okay, because it's the same thing we see with with extreme caloric reduction or with bariatric surgery, you can see up to 40% lean muscle loss. That doesn't make it healthy. That doesn't mean it's a good thing just because it's seen with other interventions. I want an intervention that's going to help me maintain muscle. It's going to help me maintain lean mass, improve my metabolic health long-term, and not be dependent on it for the rest of my life. Because that's what a lot of these studies show. When people come off the medications, they gain all the weight or more back. To me, that's not an effective intervention because you're essentially making the person dependent on the medication. So that's a big part of my concern. Now, if it's done with effective lifestyle intervention, which I would say for most people is going to be low carb or ketogenic intervention plus regular exercise. I mean, there are studies, again, Toward Health has published their experience of being able to get people off GLP-1s and saving money by preventing GLP-1s. And the same with Virta Health. They published a paper showing a successful transition off GLP-1s to ketogenic interventions without the regain of any weight. So this is what I think is the best use of it. Again, not that it has to be keto or low carb, but that's what I've seen as being very effective, that it's used together with lifestyle interventions. And look, not everybody's going to see the same benefit from lifestyle interventions, and some people are going to need or benefit from the GLP-1s in addition to it, but it absolutely has to be used in tandem, hopefully to use lower doses with a plan to get people off of it so we're not just creating this whole population of people dependent on this medication. I'm sure, that's what Eli Lilly wants, right? That's what the drug companies absolutely want. But that's not what we should want when we want the healthiest population and do the best for our patients.
Yeah, I was going to say, it sounds like exactly like what the drug companies would want.
Yeah.
You get hooked for life. For the rest of your life, you're having to pay for these drugs, right?
Yep.
So
if you own stock in the company, that's what you want too, right?
It's good, yeah.
Yeah.
But we can't, I'm hearing you say we really can't just forget about diet and lifestyle. The drugs are miracle cure and you don't have to worry anymore because there are trade-offs, even with muscle mass and whatnot, other side effects. And then obviously the cost.
Right. Even at a lower cost, there's still a cost. And when you think of a lifetime on the medication, and I understand doctors' frustration with lifestyle because reduce your fat, eat less, move more has failed and continues to fail. So if that's what's being taught and is going to fail in the majority of the people, I get the skepticism and just being like, it doesn't work. Just give me a drug that I can prescribe to my patients. Or even if they are aware of ketogenic diets or, more appropriate exercise routines, like I don't have time to talk about that. I just prescribe the drug. So we really need to institutionalize this. And as a medical healthcare society and institution, focus on effective lifestyle interventions and give them the support that we give medications. And not just say, okay, do it, but actually give the logistic support. Allow people to talk about ketogenic diets, low carb diets, resistance trainings, exercise programs, and give it all the logistics and the support and the attention and the finances and reimbursement that we do for drugs. And until we do that, we're going to be a drug-first society and commit people to a lifetime of drugs, which is not really doing them the benefit that we could be doing.
I fully agree. I'm 100% aligned. So it's really great to hear that. And I know that there's a lot of efforts that you and others are doing to try to make this lifestyle, really diet, lifestyle, exercise, a big part of our culture. It's a lot easier to take a pill. It's a lot easier to prescribe a pill than to go through all of the lifestyle stuff, right? It's hard work to stay healthy, but the point is that we need to do hard work to be healthy. Can we shift to metabolic psychiatry? So we've seen a lot of links between metabolic health and mental health. This seems to be gaining traction. You're obviously on the front lines of this. What is metabolic psychiatry and why is it gaining traction?
Yeah, so metabolic psychiatry is basically a different lens on psychiatry and mental illness, saying that actually a lot of these symptoms and these diagnoses, which are into buckets based on billing codes, but really have a lot of overlap, really at their core have to do with brain energy. And Dr. Chris Palmer wrote a book called Brain Energy, talking a lot about this. But it has to do with energy dysfunction in the brain. And when you can address that and treat that with metabolic therapies, you can really benefit and even reverse a lot of the symptomatology and the disease process that goes on in the brain. And some people say, well, isn't it all about neurotransmitters, right? It's a serotonin thing, it's a dopamine thing, and we have drugs for those. And that certainly can be part of it, but it's clear that is not the one and only I guess you could say dysfunction that's going on in the brain, but there's clear evidence of this glucose hypometabolism, inability to use glucose and transform it into usable energy, all the way down to the mitochondria, the cellular level of how that transforms energy. But being able to bypass all that with ketones and the improvement of metabolic health can dramatically improve symptoms. And now we're seeing it, not just in clinical practice, not just with patients reporting their own experience, but in research that we're funding at Bazooki Group and that others are doing, showing improvement in bipolar disorder, in schizophrenia, in major depression, in college kids with depression, even some reports of OCD and anorexia. And on the one hand, it's like this, wait a second, these are totally unrelated. They present differently, different symptomatology, but at their core, they still have an element of energy misuse, inappropriate or inefficient energy use in the brain. And we're addressing it with these metabolic therapies and seeing dramatic improvements.
That's incredible. So
yeah.
I really would love to hear about how far can these go? So with low carb, with keto, have you seen with you and your colleagues at the Bazooki Group? I know their son had an amazing story of recovering, sort of getting off medication for bipolar. Do you see people going off of their medication entirely? Do you see sort of pairing this approach with medication, changing medication, lowering? How does that sort of work? And is there, I imagine, everything in between?
Yeah, it's a great question. And so the answer is yes, we absolutely see people coming off all their medications. But at the same time, I would say that is not necessarily the goal. The goal is to get people feeling better and improving their lives. And for some, that means medications plus metabolic therapies and ketogenic therapies. And that's how I would suggest everybody start with their clinician, right? Anybody who's treating a specific medical condition with ketogenic therapy should be doing it with their physician and with their healthcare team. And what the studies have looked at is adding it to conventional treatment, to medications. What most patients do is they add it to their medications, but then many of them are able to taper off, lower their doses, or completely get off their doses. And I mean, let's face it, part of the problem with psychiatric medications or any brain-based medication is they have brain-based side effects too. And a lot of them have systemic side effects. So if someone is struggling with side effects and they can use ketogenic interventions to reduce their medications, by all means, with your healthcare team. So also at Metabolic Mind, we have a lot of content about deprescription, about medication management. So what are the concepts to think about, how to talk to your doctor and your healthcare team about it. And there are plenty of people who have shared their stories of reducing or completely getting off their medications and transforming their life with ketogenic interventions. But again, that doesn't necessarily have to be the goal for everybody. And most people should be starting it as an adjunctive therapy to their standard of care therapy.
It seems like a really powerful tool, and it's something that I think many people may hear about. They may have a mental health condition, but not know where to get started. And obviously, just like with sort of you could say mainstream medicine, mainstream psychiatry probably doesn't recognize the ketogenic low-carb approach as well. So how do they get to a practitioner or psychiatrist that could be open to this, may specialize in this, or how do they talk to their current practitioner if they're not, and sort of they want to start doing this type of approach? How do you get started in that?
Yeah, all great questions. So first I would say metabolicmind.org, right? Our website has a lot of that information. We have a list to a number of different directories that list clinicians who practice this, who are trained in this, who have experience in this. So you can certainly find them there. We have information that you can bring to your doctor and actually give to your doctor to help educate them about this. We have links to our free CME activities on My CME to help. Every doctor needs to get a certain number of hours of CME credits, and we have free credits that they can get about metabolic psychiatry so they can learn about it. So I think that's the best starting point. We've tried to create this website with as much resources as people can have. And it's nice that we're nonprofit. So you're not going to find buy our supplements, buy this, buy that. No, this is just to give people the information so they can learn about it and help educate themselves and their clinician and their healthcare team about how to do this. So I think that's probably the best way to get started. And we really need more doctors, more therapists, more nutritionists and dietitians to know about this. And fortunately, people are talking about it. You're talking about it on your podcast. You're having me here. There are people creating businesses to try and support this, books being published, and people sharing their stories. So that's another thing at Metabolic Mind. We have a whole section called Think Smart, which is an acronym for basically people sharing their stories about how they have transformed their lives with metabolic psychiatry, which is incredibly inspiring and educational to see how other people have done it.
That's incredible. So metabolicmind.org, you can go there. And I think I love what you're also saying is not just for the people looking for that for themselves, but trying to encourage sort of the next generation of practitioners, whether they're dietitians, therapists, psychiatrists, doctors, right? We all need people to be more informed and about the role of metabolic health and in mental health, right?
Yeah, 100%.
I think that's just so powerful. So, okay, so you also have this role in the Coalition for Metabolic Health. Can you tell us what you're doing there? What is the vision? What have you been working on to really get through to policymakers and sort of the research landscape?
Yeah, so at the Coalition for Metabolic Health, we are a compilation of experts in the field of metabolic health, including yourself. So thank you for being involved. With the goal being not only sort of education and as we're doing it sort of at Metabolic Mind, but for the broader metabolic health world, I guess you could say, but also the policy side to really sit down with lawmakers, policymakers, to say, how can we change this whole healthcare world that we're in to focus more on metabolic health? And here's the research that supports this. And then what areas of research do we need more of? So talking to people at the NIH of what we should be researching, talking to people at HHS, right, about the DGA and other policies. And then trying to say, how do we influence even medical schools and medical training to focus more on metabolic health? Because as I mentioned earlier, it really has been a blind spot in medicine to not focus enough on metabolic health and metabolic therapies for treating many of our chronic diseases. I mean, there's no question. You could look at any of the data to see how metabolic health and metabolic diseases have gotten worse and worse and worse. And this is with a healthcare world trying to prevent this, trying to treat this, right? Their goal has been to make people healthier, but yet we see these disease processes getting worse. So something clearly needs to change, and we are really trying to have that impact from a policy side, from an education side, and everywhere in between to really impact this. And so far, it's been amazing. I mean, we're not even a year old yet, but the group of experts that we've convened is really remarkable. Our website, it just has a number of reference of resources and papers that we've come up with the GLP-1 task force paper being one of them, but many other examples. And I like to think we did have some influence in the Dietary Guidelines. Hard to know how much was directly our influence or not, but just saying it over and over and over again is going to get people's attention.
Yeah, I really appreciate that. I saw Jan Bazuki at the DC sort of celebration of the guidelines, and I told her, I was like, I've been a part of different coalitions before, but this is the first that's incredibly active and proactive. And I just am impressed by the caliber of the scientists and the people involved who will respond to requests. Like, we got a request from the Utah state legislator about policies around SNAP and sugar-sweetened beverages and ultra-processed foods, and we were able to respond collectively as a coalition to sort of meet that need. And I'm just so impressed. We put out a response to the call for the definition of ultra-processed foods from the FDA and the USDA, and I was involved in that, and David Ludwig was involved in that. And so I really appreciate that. It's also not just all of the low-carb community. Like, there's me, who's a bit I would say, a bit agnostic to some of that, and you have other scientists who are less deep into that world. So we're looking at things more like holistic, more balanced, and looking at all the different perspectives. So I'm a big fan, even though I'm a part of the coalition. I also just a fan of the coalition. So it's good to be a part of it.
And document, sorry to interrupt, but just real quick, that document of ultra-processed foods, I think, was the perfect example, because we did have some different opinions about it, but to be able to bring all these experts together to really come to a good consensus that really kind of explored a lot of the different options, I thought was a great example of what we can do.
It's so, I found it so productive to sort of debate in this sort of constructive way with people about things and talk about what do we agree on, what's still up for debate and discussion. And, we also have these plans to sort of come up with a bit more consensus building around what types of guidelines can we give for different policymakers about, if you're going to try to do something with SNAP, or if you're going to do something for school meals or whatnot, what do you want to what is the first level of restriction, right? Like sugar sweetened beverages are obviously an easy target there. But then what about defining unhealthy processed foods, highly processed foods? That gets murky, right?
It does, yeah.
So it's been great talking with you. So let's say the average YouTube browser stumbles upon this video. They've been intrigued till now. They're still here. What would you want to say for them to take away? Just the average sort of person who's looking to improve their health. What's important to pay attention to?
Yeah, I think again, the key is focusing on metabolic health, but then understanding what that is, right? And unfortunately, it's not as simple as just your blood sugar. It is a little more complex, but it's this concept of how are you taking in food and energy, and how is your body using it? And that can be reflected in a number of different ways. But making that the number one health priority and working with your healthcare team to make that the number one priority, I think is one of the best ways people can improve their health, and doing it with a lifestyle first approach that doesn't have to be a low fat, count your calories lifestyle approach, but rather could be focusing on macronutrients, focusing on lower carbohydrate, allowing yourself to eat whole foods when they come from animals, and having that be your balanced diet, following the new pyramid, the new food pyramid, which I think really reflects science and a dedication towards metabolic health. So really getting past, it's really hard. I get people saying like, wait, this is the opposite of what I've been told for decades. So how am I just going to flip the switch? But this really is a path forward, because you can see where the old path has gotten us, and it hasn't been anywhere good. So really understanding when you focus on your metabolic health, when that is your lens, things change. And that is I think the best approach to a healthy future.
Yeah, I agree. So focus on whole foods. That's going to go a long way for many people. If you can just get that, you can cut out some of the highly processed foods, the refined foods, obviously a lot of the refined starches and the carbs that dominate the diet in the U.S. and many other countries. So Dr. Bret Scher, so great to have you. Thank you so much for speaking with me today.
Thanks, Ty. It's been a great discussion. I appreciate it.